I'd like to start my presentation by thanking you for your kind invitation to be the keynote for this first international conference of applied psychology in Sri Lanka. I've only been associated with Sri Lanka for, well, it's actually 12 months, but it feels a lot longer. I've had the great pleasure to come to the Colombo Institute of Research and Psychology, I think 4 times now, as the external examiner. I'm very delighted that the bachelor's degree has been accredited by the British Psychological Society. That's no mean thing. And I would just like to thank CERP and also the University of Coventry as well for facilitating my trip here and attendance at this conference. What I want to do is to focus on what I consider to be a really important issue, and it's one that Darshan has already touched on, which is about access to psychological therapies. And to think about that globally, not just in relation to countries that Marty Seligman had identified, those that are developing or perhaps poor or affected by famine and war, but also to think about access to psychological therapies in the so-called high-income economic countries. Because when we take a sober look, we don't actually get it right, and that access to psychological interventions is actually quite poor across the world. So that's going to be my theme. I'm going to focus on what is called the treatment gap, which is trying to quantify, if you like, the lack of access to interventions. And I'm going to look at some developments over the last decade, mainly organised by the WHO, the World Health Organization, that have actually tried to make a difference in meeting the treatment gap globally. And I think the last 10 years or so has actually seen a massive development in terms of global mental health. I'll talk a little bit about the UK. I spent 6 years helping to set up a big national program which was called Improving Access to Psychological Therapies. I was a national advisor to the Ministry of Health in England, and I'll tell you a little bit how we spent probably about £1,000 million trying to develop access to psychological therapies. And then finally, I'm going to try and share some thoughts about Sri Lanka and pick up on some of the issues that Dr. Darshan mentioned. I think recognition, registration, and regulation are all actually very important points, so I'd like to return to those. So, some context. If we travel back in time about 14 years or so, the WHO profiled mental health globally and published a report in 2001. And it was pretty damning, really. 40% of countries had no mental health policy. 25% had no mental health legislation. And where it did exist, most of those laws are at least 40 years old. Now, a couple of months ago, I gave a similar talk in Bangladesh. And at that time, their legislation was based on the 1928 Lunacy Act. Now, I have a suspicion that until this year, in Sri Lanka, I think your mental health legislation was also based on the 1928 Lunacy Act, but I'm pleased to say, I think, that it's currently been revised and brought up to date. 28% nations had no identified mental health budgets, and most of them invested less than 1% of their health budget on mental health. So the overwhelming global picture was really that of neglect. Now, as I've hinted, the last decade, I think, have seen some significant improvements. So we have an awareness of the importance of mental health, both globally with WHO and also within the UK. One of the big cries, if you like, at the moment is equity. There should be equity in terms of the provision of physical health care and mental health care. There have been a whole series of reports that have been published in the last decade or so about how mental health might be improved. So in 2009, there's a report on looking at systems of delivery of health care globally. A very important report the following year, which was about the economic impact of poor mental health, both in terms of the people who experience poor mental health, but also the interaction with nations' wealth. And that's something that I want to come back to. Very important guide was published again a few years ago called Mental Health Implementation Guide, which was all about scaling up mental health interventions within low to middle income economic countries. So it was saying, here are a set of interventions that have an excellent evidence base, and here are some ways that you might be able to introduce these interventions within your health system. So, as the Minister has already said, very much a practical focus in terms of implementation. Recently, there was a mental health action plan that tried to establish a set of principles and a set of goals. And very recently, and in fact very important from my opinion, is the whole issue of deinstitutionalization. There are far too many large warehouses in our countries for people with mental health or psychiatric problems. And if we're really going to seriously think about providing psychological interventions within community, within primary care, then one of the things we need to address is actually trying to reduce our reliance on those large psychiatric hospitals and institutions. So a lot has happened in the last 14 years or so, and a lot has been published as well. So I'm proud to say that the Lancet, UK medical journal, has had a number of issues that have been devoted to global mental health. There have also been a series of really quite key articles about developing mental health services in low to middle income countries. I want to focus on a key concept which I mentioned earlier, which is the treatment gap. And the treatment gap are the percentage of people with a disorder that go untreated. They receive no intervention whatsoever. And generally speaking, this is a balance between the prevalence of a disorder and the resources that are available to treat it or provide intervention. It differs significantly across countries due to both those factors, But also there are some other more subtle issues, such as the recognition of disorder and also the stigma of mental illness that varies. The treatment gap was identified in a number of articles within The Lancet, and there was a focus on Europe. So although 27% of people every year experience some form of mental illness or mental disorder, 74% of those people receive no treatment. So even from a European perspective, we're actually doing very poorly in terms of allowing access to treatment and intervention. And interestingly, within The Lancet, the analysis was that actually this isn't just a problem for mental health professionals, but it's a problem for the whole of society. And they were advocating a socio-political campaign of sustained advocacy in order to overcome the barriers to scale up mental health provision. Saxena, in the same article, looked at the issues globally, and the inequalities become even more stark. The US has more psychiatrists than India, China, and Africa put together. So access to health professionals, huge inequalities across the world. And globally, 2/3 of people go untreated, up to possibly 90% in low middle income countries. So access to mental health treatment is really quite dire. Now, much of this is obviously to do with resources. And if we look across different countries in terms of their economic standing, we see huge differences in the provision of mental health services. This is quite a sort of busy slide. You can break it down into different professions. So again, huge disparities between psychiatrists, psychologists, psychiatric nurses, social workers across economic countries. And unsurprisingly, this also follows through in terms of provision of services. So this is a very busy table. You can read it in the Saxena article, but again, essentially what it's saying is low or lower to middle income countries, the development of specialist services within mental health, or the provision of psychiatric beds or community or primary care is very, very underdeveloped. However, we shouldn't just think of the treatment gap in relation to finance and resources. There are some other really important psychological factors that determine whether people get to see mental health treatment. Probably the most significant is stigma and help seeking. So actually, the problem lies with the patients themselves, or in fact not the patients, but the people, because many people are reluctant to become patients. So many people are reluctant to seek treatment and intervention. And this is the case even in high-income countries such as the UK and the US. So despite a massive investment in availability of psychological therapies within the UK, only about 50% of people with depression will actually come forward and seek out some sort of intervention or treatment. And it's similar in the US. In fact, the figures are more worrying in the US, that only about 1/3 of people with mental health problems actively seek out treatment. For other disorders such as schizophrenia, because of its disabling consequences, the percentage of people that seek treatment is generally higher. However, it's interesting that in countries such as Australia, because there's almost, if you like, a fear of the consequences of being treated within mental health systems, that young people with psychosis are actually very reluctant to come forward and to seek treatment. So the percentage of people that are untreated also links to the ability of those folk to come forward and to actually seek help. So it's not just a function of resource. There's also another important factor, which is if they seek help, are their mental health problems recognised? So this is the whole issue of detection. It's the issue of detection within primary care, and whether our general practitioners, our medical practitioners, are sufficiently well trained in psychiatry and mental health to actually detect mental health problems. And again, treatment avoidance is very common, even in high-income countries, such as the UK, where there's free access to mental health treatment. There are also differences in the utilisation of psychiatric services. Some of these are probably ethnically and culturally determined. So people from some cultures very mistrustful of psychiatric services and would have a preference to rely on more traditional or perhaps more spiritual or religious solutions. I've already mentioned stigma and the negative effects of diagnoses, the impact of having a mental health problem on employment, the existence of dehumanizing treatments and fairly inhumane interventions, as Darshan has mentioned, in terms of big, large psychiatric hospitals or high doses of psychiatric medications, that not surprisingly, people are very wary of engaging with psychiatric or mental health services. What should we do about this? Well, a lot of it is about public perception. So we really need to educate the public about mental health, and they need to be positive messages. So we need to talk about the importance of well-being, the importance of good mental health, and also to think about some of the, some of the negative impacts of mental disorders, but to do so in a more constructive way in terms of what we can do to actually help and treat. And we should have an emphasis on a recovery, the fact that people can recover from mental health problems and to lead more fulfilling and positive lives. As I said earlier, the other issue is around detection and recognition. So we need to ensure that there's greater awareness both within the public and also in the relevant professionals about detecting psychological problems. There's also poor knowledge about the effectiveness of mental health interventions. Again, the last 20 years has seen a big emphasis on evidence-based medicine. And if you look at the measures of effectiveness, the effectiveness of psychological interventions for depression and any psychological intervention, so I'm not just talking about CBT, but also psychodynamic and interpersonal therapy, they are much more effective than many medical interventions that we're commonly aware of. So if you look at the measures of efficacy, actually psychological interventions are some of the most potent medical interventions that we have. And there's ignorance about the efficacy of talking therapies, and also the fact that talking therapies can be used in many different groups. Okay. What other factors affect the treatment gap and the delivery of mental health services? Well, obviously there are a whole set of socio-economic factors, or socio-political. So political will and poor funding. Again, it's about forcing mental health up the agenda so that the politicians and the public become aware of it. Mental health resources are frequently centralised in big cities and in big hospitals, and it's difficult to get those resources out into the community or out into the countryside. In a lot of low middle-income countries, and I think this goes for Sri Lanka, the focus has been on primary care workers being educated around mental health so they can help to deliver services. The problem there is that those primary care workers actually have their hands full delivering other interventions such as good women's health, maternity services, HIV and AIDS, etc., but they don't really have the time or the resources to devote to mental health. Low numbers of mental health professionals, poor supply of psychotropic medication, and poor leadership in public mental health. These are some of the contributing or additional contributing factors. So, some solutions, and this is where the WHO has come in, and they've published a whole series of reports and initiatives and joint projects in various different countries about what can be done. So there was a report that identified different services of delivery for mental health and tailoring them to the economic status of different countries. The Mental Health Gap Intervention Guide is a crucial document that identifies interventions that can be scaled up in low to middle income countries, interventions that are based on the available evidence and that can be implemented within non-specialist primary care community services. So again, if you're not familiar with this guide, I would strongly recommend that you look through it. There's a mental health action plan, which again is about developing this globally. So the principles are universal coverage, human rights, particularly those within large institutions or residential care, evidence-based, life course approach. Mental health is not just the province of mental health professionals. Good mental health and well-being, we also need to think about housing, education, employment, judicial services. So we need to have a much broader perspective. And also involve people with mental health problems themselves in the design and the delivery of their services. So the objectives of this action plan are strengthen leadership, try to produce more comprehensive, integrated, community-based services, mental health promotion, and also information systems and research. On the research note, the National Institute of Mental Health within the US has identified global mental health as one of its grand challenges and has set up a 10-year research agenda to take this forward. And in fact, there was even a publication in Nature, which is the foremost scientific journal within the world, actually saying how important these grand challenges are in terms of global mental health research. And then finally, as I mentioned before, there's this whole issue of decentralisation, producing community services, and scaling back and closing down our large psychiatric hospitals. And there's a report about how to try and achieve this. Various different models of care have been suggested. Really important paper by Thornycroft and Tanzella looking at different blendings of community primary care and specialist hospital care across different settings. Just a word of caution, there's quite a nice paper by Ross White, who is a psychologist, published in the British Journal of Psychiatry, that says that we should be mindful of what we're doing when we're helping to advise developing countries around mental health. Goes without saying that diagnosis is affected by cultural and diversity issues. We need to be careful about transcultural psychiatry and not introduce a new form of Western colonialism within mental health. Far too much over-reliance in terms of psychotropic medication. There's a lack of research into mental health provision within low middle income countries, so we need to find out what works specifically. And there's a sort of an assumption that the high economic countries do it better, and that may not necessarily be the case. We know that extended families, we know that factors such as more community involvement and less individualism might actually be better indicators of good well-being and mental health. So it may be that many of the low and middle income countries have family structures and community structures that actually support well-being much more effectively than perhaps in the West. Involvement of users has been underdeveloped, and also we need to think about local solutions and also other traditional approaches to mental health. So that's my sort of global perspective on the treatment gap. I want to say a little bit about what I think the situation is in Sri Lanka, and this is, me doing a little bit of searching on the internet. And I want to tell you a little bit about a project that I was involved in the UK, and then come back and address some of the issues that Darshan mentioned about applied psychology within Sri Lanka. So, mental health in Sri Lanka. Relatively high prevalence of anxiety and depression, particularly in children and young people. And I guess that's not surprising given the sorts of challenges that your country has experienced in terms of conflict and the tsunami in the last 10 years or so. What I was surprised at was the high suicide rates, and you have one of the highest suicide rates in the world, particularly for women. High levels of substance abuse, high levels of domestic violence towards women as well, and clearly impact of natural disaster and conflict. So I guess mental health is an issue in Sri Lanka. I mean, it's an issue in every country, but I think you have some particular challenges. Policy and budgets, well, where does Sri Lanka lie in terms of investment within mental health services? And actually it's quite difficult to work out because your mental health budget is tied up with your overall health budget. So it's actually, well, it was up to a couple of years ago difficult to actually tease that out. I mean, it may be clearer now. Rachel Jenkins visited, I think, about 3 years ago and did some really important training of medical practitioners around mental health and wrote up a really nice positive article about mental health provision within Sri Lanka, and this is where some of these figures came from. Until this year, there hadn't been a modern mental health legislation, although I believe that has now changed. You do have a mental health policy, and that's being reviewed and will be renewed, I think, in 2015. Human resources and staffing. I mean, I'm sure there are no surprises here. You train many psychiatrists, but the majority of them go abroad to practice. So retaining mental health professionals within your own country is really quite difficult. And as Darshan was implying, there are very few psychologists who are actually employed within the government or within the health service. So that's the situation as it stands at the moment. So what we need to think is where we can go in the future. So I just want to say something about the role of psychological treatments and psychologists in addressing these gaps. And the first thing I want to say is about the effectiveness of psychological interventions. Now, there's a popular book that's just been published in the UK, and it's called Thrive. And it's about the positive impacts of psychological evidence-based interventions, mainly CBT, and it's been published by Richard Layard, who's an economist, and David Clark, who is a clinical psychologist. And in it, they review the evidence for the effectiveness of psychological interventions. And the evidence is overwhelming, and it's reproduced in our clinical guidance, which is from an organisation called NICE. What these authors do in this book are to put out the argument for access to psychological interventions on a global basis. There's also an economic case, which is people with common mental health problems quite frequently lose their jobs, become unemployed, and in various countries become dependent or reliant on benefits. So there's a loss of output and income. The individual loses income and social status. That usually results in problems for themselves and their families. And society loses out in terms of productivity and also has to bear the cost of benefits and treatment and rehabilitation of those folk. And Layard estimated that the economic impact of anxiety and depression cost the UK £12 billion a year, of which £7 billion comes from the Treasury. And he argued that if we could treat common mental health problems such as anxiety and depression more effectively, we would save money as a nation. And this was the argument that he put forward to the Treasury within the UK and was the basis for the Improving Access to Psychological Therapies programme. And I'll say a little bit more about that in a minute. Would psychological treatments be as effective in developing countries or non-Western countries? We must ask ourselves that question. But actually, when you look at the evidence, there's quite a lot of research to suggest that they do pretty well. So there's work in India, in Uganda, and Pakistan, showing the effectiveness of CBT for common mental health problems. Frequently, though, the interventions and the supervision needs to be modified. So it needs to be delivered within a local context rather than the context of perhaps UK or US health services. And we also need to think about the impact of culture on the delivery of psychological therapies. Sorts of treatments that should be available are things like psychological first aid following disasters, psychoeducation, mental health promotion. So this is this whole business of increasing the awareness of the public, psychological self-help, one-to-one psychological therapies, group interventions, and also specific responses to trauma. Who should deliver them? This is, again, a busy slide, but it was a review of mental health workforce issues that was published in The Lancet recently. And essentially what they're saying is that in many developing countries, we need to think about more flexible approaches to workforce development. So we shouldn't just rely on the idea that we train lots of psychiatrists and lots of psychologists. We need to think about how we can train people in mental health interventions within communities and within localities, including lay people as well. So it's suggesting a much more flexible approach to workforce development. And in fact, I'm pleased to say that Sri Lanka is out there in the lead when it comes to psychiatry training, and that you're being training medical officers of mental health who are, as I understand it, general practitioners who have had a short program in psychiatry, which offers them a much better informed approach to mental health. Okay. Just want to briefly say what I've been involved in the UK. In some ways, it's quite similar to what you've been doing in Sri Lanka, because we've been trying to increase access to psychological therapies, but it hasn't been profession-led. We haven't been trying to up the numbers of psychiatrists and psychologists per se, but what we've been trying to do is to train specific therapists to deliver particular therapies. So I would describe it as a client-led, bottom-up approach. So we start with the needs of patients and the sorts of services that they require. We think about the type of workforce that can deliver that. We think about the sorts of skills and competencies that workforce needs, and then we think about how we're going to train it, and also the quality assurance and registration and regulation. So rather than starting with the profession, we start with the needs of individual clients and the sorts of therapies and the sorts of therapeutic competencies and skills that they require. Another important thing is stepped care services, which is about delivering to people a sufficient intervention that's effective. But it might be, well, it has a number of principles. One is least burden. So it's a little bit like a therapeutic dose in pharmacology, that you give the smallest effective dose that gives you a positive outcome. And we can think about this in terms of mental health provision. This is within the NICE guidelines, and it's about interventions for depression. And there are 3 columns, and there are different steps in each column. So if you look at the column on the far side, you've got different sorts of interventions. So it goes from watchful waiting up to inpatient care. In the middle, you have different severities of depression. So people with moderate to severe disorders clearly need quite major interventions, such as medication or psychological support. Whereas those with fairly mild disorders can be treated perhaps within primary care, perhaps by counsellors or practice nurses. So what you see are different steps, different dosages, different degrees of intervention, depending on how severe the disorder is. And this is the principle that has underlie improving access to psychological therapies in the UK. And also, we've developed new roles. So we've actually created, a bit like your medical officers in mental health, we've created a new profession that we call psychological wellbeing practitioners. So essentially, we have a skills mix. We have a group of people who deliver low-intensity, brief interventions for anxiety and depression. So this might be guided self-help, computerized CBT, behavioral activation, usually about 4 to 8 sessions, quite often quite brief sessions. And these folk are trained a day a week for a year. On the other hand, we also train CBT therapists, and these are folk that will give 16 sessions. They're trained to a much higher degree of competency, so their training is 2 days for a 12-month period, and great focus on supervision. And we tend to train other therapists, so we're not starting from scratch, and what we're trying to do is to upskill them in evidence-based approaches such as interpersonal therapy, brief psychodynamic therapies, couples therapy, and also counselling as well. What have we achieved? Well, in about the last 5 years, all areas in England now have an improving access psychological therapist service. By next year, we will have trained 6,000 new therapists within the UK. Over 1.5 million people have been seen. About a half of those have completed treatment. And from an economic point of view, the thing that hits the button for the Treasury is that quite a large number of people have moved off benefits and sick pay and are back into employment. Current recovery rate's a bit low, it's only about 46%, and at the moment we're probably accessing about 10% of people that need those services. If you're interested in ICAP, then go to the website. There's lots and lots of information there about training, about workforce development, etc. So I think I've got about 5-10 minutes left. So I just want a few thoughts about applied psychology from a Sri Lankan perspective. And I think there's some sort of key questions. So what should we be thinking about in terms of the psychology workforce? What are the different roles of applied psychology? And how should these roles be reflected in the education and the curricula that we design? Are there other psychologist roles? So just as you've developed new roles for psychiatry and medics within Sri Lanka, should we be thinking of developing new roles around psychologists within Sri Lanka? What about this notion of a psychological well-being practitioner, which is like an assistant psychologist? How much effort should we spend training other professions as well in psychological approaches? And what are the implications for all of this in terms of registration? I think some of these questions are really, really tricky. If we ask ourselves, well, what should the psychology workforce look like? And we look to countries such as the UK, the US, Australia, New Zealand. Clinical psychologists tend to train for at least 3 years. They're required to perform supervised placements or an internship. Within the UK, the majority of our registered practitioner psychologists now have to have a doctorate within psychology, and again have to meet that 3-year requirement. So I think one of the challenges for Sri Lanka is whether you wish to aspire to that international standard. And I put it that way because, there's a question there, isn't there? I would suggest also that you think about different steps, that you don't put all of your eggs in the doctoral basket, because I think you need a flexible workforce. Unfortunately, although there's a Sri Lankan workforce plan and survey conducted by the Ministry of Health, psychology doesn't feature in it at all. So I think you need to think about that recognition issue. How do you get on the map? What should a doctoral clinical psychologist be? Well, they should provide both public mental health and clinical leadership in psychological therapies. They should help design and evaluate services. They should be expert therapists and trainers. And they should supervise others. And I think, again, there's a challenge in Sri Lanka about how you're going to develop that class of clinical psychologists. I'm aware that there's an MPhil, 2-year MPhil, I think, at the University of Colombo. But how does that also fit in with the diverse landscape of applied psychology? We also need to think, as I hinted before, about training other folk at different levels in different types of psychological interventions. There's a question as to where the 1-year master's in applied psychology fits into all of this, because that's a lot broader than just clinical psychology, which has been my perspective today, and how these fit into the clinical psychology workforce. Big problem, again, about registration and regulation. Most of the effort in the West has gone into trying to regulate clinical psychologists or applied psychologists, and healthcare assistants or assistant psychologists, or in the UK, psychological well-being practitioners are currently unregulated. So we need to think about how we regulate below that level of professional psychology. And I was kind of surprised that I think there's something like 5 registered clinical psychologists in Sri Lanka, and they're registered by the Sri Lankan Medical Council. Okay. Implications then for sort of degrees, qualifications, associated curricula. Well, I think essentially they should be fit for purpose. So I think you should design your curricula in terms of what people are going to do. And I think the issues that you face, and again, I think this is similar to some of the things that Darshan said, is I think you need to try and come up with a common approach, a common platform within Sri Lanka for all branches of applied psychology. I think you need to think carefully about the differences in qualification, length of training, access to placements. I wouldn't pretend to know about the provision of undergraduate psychology education in Sri Lanka. I think there's an important issue there about how undergraduate and postgraduate link together. In the UK, we're fortunate in as much as undergraduate psychology is one of the most popular disciplines. And interestingly, it's not it's not just dedicated to the privileged classes. I mean, psychology is attracted to everyone in terms of working class kids and kids from ethnic backgrounds. The only people we see not to attract are blokes, men. So there's a huge gender difference. I think you need to think about how you can integrate some of your applied psychology specialisms, think about the professional standing of other psychologists, such as educational psychologists, forensic. How are you going to train other professions? Because I think training other professions in psychology is important. And then there's this whole issue about autonomous practice as well, which I guess I would decode as being able to operate independently as psychiatrists. I think this is almost the last slide. Some possible solutions. I think you probably need a Sri Lankan Psychology Society to embrace all of this. I think you need to work more closely with your National Institute of Mental Health. You need to ask the question, where will psychology fit in the next mental health policy for Sri Lanka, which I think is going to be published in about a year's time. I would think about developing a workforce plan for psychology and a review of training within your country. Increasing numbers and supervision and clinical placements will be a real challenge for you. And to revisit the registration and regulation issue. If you're interested in psychology in other low and middle economic income countries, the BPS, the Division of Clinical Psychology, published a special issue a few months ago, which you can download from their website. And finally, I've got one little thought to leave you with, which is not to underestimate the challenge that we've been talking about. There's a really nice little thing. I mean, this grew up in the States, and a lot of the thinking is associated with Obamacare and access to healthcare generally. And it's called the Iron Triangle of healthcare. And it's got cost, it's got quality, and it's got access. And obviously, we would like to improve all three of those. We'd like to decrease costs, we'd like to increase access, and we'd like to increase quality. But in reality, you can really only do two sides of the triangle. So if you want to increase access and quality, cost goes up tremendously. If you want to decrease cost, then that's usually at the cost of quality and access. So it's a good thing to think about, and I think it grounds you. So thank you very much. Conclusions: treatment gap exists across the world. We're not doing particularly good in the West. Improving access to psychological therapies requires a public health approach. Adequate services need financial and political support. Flexibility is required in terms of the sorts of interventions that people have access and who delivers them. Interventions have to be acceptable to communities and to cultures. And applied psychologists at all levels of training have an important role to play. That's it. Thank you.